Hello, and welcome to the symplr Education Series webinar. Today's webinar is Enhance Your Patient Safety with the Cactus Quality Suite with Joni Orand. Next slide, please. I would now like to make some introductions. Next slide. Today's webinar is brought to you by symplr Compliance and Credentialing for Healthcare. I would like to let you know that at the end of this webinar, we will have time for a formal Q&A. Please submit your questions via the chat box on the right side of your screen. We're so happy to have Joni with us today to talk to you about these products. She is our Senior Consultant Specialist here at symplr, and you will find all of her information here on the screen. I'd love to hand it over to her now.
Thank you, Callie. Good afternoon, everybody. Thank you for joining us today by phone. It's nice to meet everybody by phone. I know you're muted, so you can't really say hi to me, but I appreciate your time. I appreciate you joining the webinar, and hopefully you have some lunch that you can eat. So I know lunch times are important too, so we really appreciate it. I want to just start out today by kind of backing into this a little bit. Let's just start from the basics in the very beginning. We're going to talk about how patient safety and quality and how symplr can help you with that. But let's just back up to what is patient safety and quality. I'm sure most of you know, but some of you may not, or some of you may not know all the details of how this came about and the history of it. So I want to go over that a little bit first so we kind of all know what we're talking about. And then from that point, we'll begin to discuss how symplr can help you with these things and assist you with these things, and hopefully save you a lot of time and resources. On the screen now is a little funny to start off with. It says, Nurse Adams, please report to rooms 13 through 100 immediately. You have patients who need your attention. So if you're in management, if you're a nurse manager, if you're a director of quality, these type of folks, as you know, you have 100 things going on all day and probably within every couple of hours. So time is a big factor and issue here, and we can't always think about safety and quality every minute of the day, nor do we have time to fill out forms and reports and things all day long. So that's a factor that's involved with patient safety. So hopefully we can make this a little bit easier for you. This is, what is quality? Let's just start there. What is it? We all use that term. We always discuss quality, but what is it really? The definition, the Institute of Medicine defines it as healthcare quality is the degree to which each healthcare service, whether it be a hospital, a hospice, a home health, anybody involved in that continuum of care, for individuals and populations, increase the likelihood of desired health outcomes and are consistent with current professional knowledge. So we're looking at how does this work from the time a patient goes to their doctor or has some sort of health issue to the time that the professional gets involved, and then what are the outcomes? How does it turn out? So for the time you go to the doctor as a patient until the time maybe you're admitted to a hospital or a facility, a surgery center, you have a procedure or a surgery or whatever the case may be, then you leave the hospital, maybe you go to home health, maybe you go to hospice, and so on. So there's a whole continuum of care there. And the definition of quality covers that continuum of care from the time they enter until the time they're actually gone from us, till death in hospice and so on and so forth, eventually. And the likelihood of a patient coming in and out of this continuum over and over and over consistently is very high. So we want to be able to trend and track outcomes from this. How do we handle each step of the way? And who was involved in each step of the way, so to speak? And how are we going to handle those things? So that's really the definition. We've got to cover every aspect of quality. Now, patient safety emerged as a central aim of quality in the early 2000s. It was just included in with quality, and patient safety became a pretty big factor there. And I know for a lot of you on the line, you have different areas or different people responsible Maybe one person's responsible for patient safety or patient complaints, another person's responsible for risk management, another person's responsible for quality, and so on and so forth. But honestly, patient safety became a part of quality in the early 2000s. So patient safety, as defined by the World Health Organization across the world, is the prevention of errors and adverse effects to patients that are associated with healthcare. Pretty simple. Safety is what patients, families, staff, and the public expect from Joint Commission accredited organizations or D&V organizations. So they know if you're an accredited facility, they're going to expect this. I expected it yesterday. I took my mother to the ER last night. And long story short, I was expecting that all along the way, and I was a little disappointed in a couple areas. So everybody, when you enter a facility or organization, expects to be safe. And then while patient safety events may not be completely eliminated, harm to patients can be reduced. And the goal is always zero harm. Nobody's perfect, but that's our goal. Approaches and methods should be adapted by a healthcare organization that aims to increase the liability of its complex systems while making visible and removing the risk of patient harm. So then we come into risk management and some other areas there for liability that are pulled in. Accredited organizations should be continually focused on eliminating system failures and human errors that may cause harm to patients, families, and staff. Not just patients, but your staff as well. We want to keep them safe. So all of this plays into our quality at this point. The first set of national patient safety goals was established in 2003. Sentinel events, alerts, standards, and survey processes, performance measures, educational materials, etc. were introduced. Lots of indicators and things that you need to be tracking and trending. Some people call them triggers to reach these goals. Following a solicitation of input from practitioners, provider organizations, purchasers, consumer groups, and other stakeholders, the Joint Commission determines the highest priority for patient safety issues and how to best address them. So around 2003, JC said, look, we're going to get some input across the health system from different groups, and we're going to start to put together priorities, issues, and how best to address them. The Joint Commission also determines whether a goal is applicable to a specific accreditation program, and if so, tailors the goal to be program specific. And then, of course, they ask you to demonstrate that you have these goals in mind, and how are you following them? How can you demonstrate that you have? What is the outcome of that, and how are you handling it when things go awry or don't go so well? So all of this is really left upon the organization, the facility, to demonstrate these things and prove these things. These are the goals of patient safety here. And again, you all can have these or get a copy of these if you like, but essentially you probably already have them or should have them. But just to reiterate what we're including in quality is we want to identify patients correctly for patient safety, of course, from the time they come in and during surgery and procedures and so on and so forth. We want to make sure that we have the correct person. Number two is improve effective communication. Well, that's really clear, isn't it? So that's a very broad spectrum there. So we have interpersonal communication. We have communication between provider and patient. We have communication between reception and admission and all these folks. So to improve effective communication is a little vague, and I'll talk about that in a few minutes, but we can certainly assist you with that and give you some indicators and ways that you can demonstrate that you are improving and having effective communication. The third goal, of course, is to improve the safety of high alert medications. We want to make sure that we keep everybody safe with medications, especially the high alert medications. And again, trending and tracking there is so important with wrong medication or medication errors and things like that. So we'll be discussing that goal and how our products and systems can assist you with that, so you don't have to try to figure that out. The fourth goal is to ensure correct site, correct procedure, correct patient surgeries, of course. We want to be able to do that. And then again, if anything is done incorrectly there, or we have any issues or concerns, we want to be able to demonstrate how we made corrections and what the outcome of that is. And then, of course, trend and track those things to try to manage them and make sure that, we don't have those reoccurring. We'd also like to be able to tell, where are we having most of our issues? Where are we having most of our problems, or things happen here, or mistakes, or whatever the case may be? How do we know? You have lots of departments in a facility and lots of specialties and lots of things going on. So how do we know where we have the most events happening, or patient safety goals are not being met, and so on and so forth? And we want to be able to trend and track those things. So goal number 5, reduce the risk of healthcare associated infections. Infection control is where this plays in here with our infection control department and person responsible for those things, and nurse managers and staff and so on and so forth. And again, we want to be able to trend and track anything that regards infection control. Then goal number 6 is reduce the risk of patient harm resulting from falls. And falls is a huge problem and indicator, and probably one of the most categorized events or incidents that are tracked. Falls can be, tricky. Falls can be more than one incident or event. Maybe the patient was over-medicated and fell, but we found out the floor was wet as well, and they were told not to get out of bed, we thought, but the nurse forgot to do that. So there's many, many different triggers and things that can enter into each one of these goals, and we want to be able to help you with that. What departments or areas in your facility are responsible for patient safety? Well, pretty much everybody, right? So we have infection prevention and control, that area. We have quality improvement, which could encompass a lot of things, but it's essentially your quality department or folks. We have risk management, who tries to keep us safe from lawsuits or, any physician issues where they might get sued, malpractice claims, things like that. We also want to make sure that we're not providing a risk to any staff or patient families or patient complaints and things like that. So risk management is certainly involved in the whole quality process. Utilization review can be involved, as well as utility system management. We may even have devices or hardware or different things involved in patient safety, not just people. So we want to track those things as well, anything in our system. And then quality improvement is, last but not least, the area where we want to trend and track and correct our outcomes and what's going on. So if you all are like me, I've been in healthcare for 25 years. When I worked in hospitals, we would have, quality might be on the 3rd floor, and then med staff would be on the 1st floor by admin, and then patient safety might be upstairs on the 3rd floor with the DON and her department up there, and then we might have risk management in the basement, and so on and so forth. And none of these departments really talked with each other that much up until probably 2005 or 6 or so. We didn't have to. It wasn't a requirement, really. We all did our own thing, and everybody did their own quality things, but that is not the way it is now. Everything that you do now to get paid well and to have your quality standards met and your Joint Commission audits go well involves you being able to demonstrate that you all are doing this as a team, and that this is happening across that continuum of care. So every department now has to speak with the other department. Every department now has to work with the other department. And therein lies some of the challenges at times, because, are you going to walk to the 3rd floor and talk to quality? Or are you going to go back over to admin and gather some data there? We're probably gathering data from a lot of disparate systems that we've been using for a while. You might have 4 or 5 or 6 vendors that you're storing information in that you're going to need to demonstrate your quality. So one of the goals of symplr is to certainly help you with that and help bring these departments together so that you can start to trend and track and look at your outcomes over that continuum. So quality and safety are can't talk today, inextricably linked. The components of quality management should include these following 3 areas. You want to ensure a reliable process, and those processes are typically up to you. You're going to have policies and procedures, you're going to have workflows, you're going to have bylaws, you're going to have things in your facility that need to ensure that there is a reliable process. And people can refer to that, they can look it up, they can have it available, and they know what it is. Then there needs to be focus on achieving better outcomes. So we know what our policies and procedures are. We know what we're supposed to be doing. We know what we're supposed to be following. But how are we constantly achieving better outcomes with that? And then using that evidence that we can gather to ensure that a service is satisfactory. So again, we need to be able to demonstrate that we're doing these things. And sometimes that's a little difficult when you have 4 or 5 or 6 disparate systems and everybody's trying to gather data from somewhere. And a lot of times that's a very manual paper type of process. So we're with you. We feel your pain. There is a huge overlap between risk and quality. So risk and quality functions, they overlap with patient safety. And you can see here that risk on the left-hand side is typically responsible for accreditation compliance, claims management, contract reviews, corporate and regulatory compliance, enterprise risk management, if it's a health system, ethics, legal, mandatory event reporting might fall under them, patient relations. It may not be exactly like this in your facility, but this is typical. All the policies and procedures typically originate there or held there. Risk control, risk financing, and so on. Workman's comp a lot of times is in that area as well for your staff incidents and staff things that happen. So, and then on the right-hand side, you'll see quality is typically responsible for accreditation and coordination, benchmarking, best practices, clinical guidelines, improvement projects, patient satisfaction, peer review sometimes, provider and staff performance and competencies of allied health and staff, quality of care reviews, quality management, core measure data, things like that, quality methodology, and then utilization and case management. Then the two sort of intertwine here in the middle. Both can be responsible for these things you see in this dark gray middle area here. So they have to work together. We need to have an analysis of adverse and sentinel events and trends. We need accreditation issues, board reports, corrective action plans, our culture of safety, feedback, patient education, patient safety initiatives, and so on. So these areas in the middle are the areas that we need to be able to coordinate between risk and quality for patient safety as well. So again, the overlap, again, the need, so to speak, for us to be able to coordinate efforts and report across the system. So I just wanted to kind of start there with you because I wanted to point out how important it is to recognize how these things originated and why we have to currently do this process and want to do this process most of the time. So here are some attributes needed for quality. These are the 6 attributes that are considered in a quality department or quality across the organization. They are safety. Of course, patient safety, staff safety, all of those safety goals we talked about. It also needs to be patient-centered. I have to feel comfortable as a patient when I come to your facility. I want to feel safe. I want to feel attended to. I want to be important. And I certainly want my care to go well. So there needs to be a really good feeling when I leave that facility and think the outcome needs to be well for me in order for me to feel safe in your facility. It needs to be patient-centered. Communication enters into that. You know, I went to a seminar a couple months ago and they discussed the fact that now hospitals have to be an experience versus just a visit. So the new millennials and this new generation want an experience everywhere they go. So Starbucks needs to be in there, or a coffee shop, and a gift shop, and we want an experience. And we have one of our clients that don't mind me using their name in Owensboro, Kentucky. That is actually the hospital I was born in. And they just built a new facility. And when I walked into the front of the hospital, it looked like a ski lodge. It was absolutely beautiful. The outside was all rocks. There was little fountains. I mean, it was so soothing to walk in that facility. And when I walked into the lobby, there were little water fountains and nice soft music playing, and it just felt so good to walk in there. It was extremely clean and meticulous. They had a beautiful gift shop, a Starbucks, different things. I felt walking in there so safe and so pleased and so comfortable and so relaxed. And that's certainly where we want to get to. That's just a great example of a hospital that I visited, and I'm sure your facility is working toward those things as well. I grew up in the military, in the Air Force, so our hospitals back in the 60s were green chairs and green walls and linoleum floors. So very scary experience when I went to the doctor. So as those things are really changing over time. So not only do you have to be cognizant of everything else, you need to be cognizant of what my experience is as your patient. And that will give you higher scores and so on and so forth. So that's really important. Number 2. Number 3, timely. Don't want to wait all day. I don't want to be there for 7 hours at registration and waiting to get my x-ray and so on and so forth. So we want to be timely. Effective. We want to be effective in whatever we're doing. Efficient. We want to use our time and our resources and our money efficiently. And then equitable. We want to make sure that we are generating the most income and revenue that we can and using that revenue accordingly. So all 6 of these attributes are really needed for quality. Then we have the Joint Commission standards, the 6 core competencies for quality. They are interpersonal communication and skills, medical and clinical knowledge, patient care, practice-based learning and improvement in their specialty, professionalism, and system-based practices, making sure things are cost-effective in how they're using things in their practice. And these are the 6 standards that we need to be trending and tracking. You can use focused evaluations for this. You could include this in ongoing evaluations for your providers and your allied health, and so on. So you want to center those evaluations around these 6 quality standards. Now, how can we help with all this? Hopefully we can. symplr can help you meet all those attributes and standards that I just mentioned, and then demonstrate it. That's really the key. Nobody tells you exactly what you have to do. Joint Commission doesn't say, here's how you do an FPPE. Here's what you need to, here's how you need to report it. They just say that you need to do it. You need to do focused evaluations. You need to do ongoing reporting. You need to do peer review. You need to do these things, and you need to be able to demonstrate that you are doing them. But how? So hopefully our products here at symplr can assist you with this and make it a lot simpler as we name the company. So that's one of the reasons we named it symplr. We want to make it simpler for you. We want to help you. So we have 3 quality products that I'm going to be walking through here. And these products will not only assist you in gathering your data, but also reviewing and managing the data for improvements, and also demonstrating and showing the outcome and the action taken and the result, and so on and so forth. So we're going to help you with that whole continuum of care, and that continuum of demonstration that you've provided the care. So these are all web-based products. They're SSL secure, HIPAA secure, meet all the Joint Commission standards, really as secure as we can possibly get them. And a lot of times I'll have physicians or somebody ask, well, how secure is my peer review data going to be in here? Or how secure is my FPPE report or whatever? I don't really want everybody seeing, what we're doing online. So, and really how I compare that is if you're doing your banking online and you trust your money online, then you can trust this online. We've met every security that we can possibly meet, and everything is encrypted. So even if they're not going to be able to read it. So we've made it as secure as possible. It's also very user-friendly, a lot of point and clicking. You can actually run reports with a click of a button. You can run your OPPE report with a click of a button. There's icons you click on, drop-downs you click on. There's not a lot of input or typing or things that you have to do. So we made it as user-friendly as we could. It is also configurable. Most of these products I'm going to show you are extremely configurable. We know that every organization is doing their peer review different. They're doing their focused evaluations different. They have different workflows and different ways that you do things in different facilities. So we want to be able to make it configurable to your workflows, your bylaws, and your policies and procedures. So essentially, we're just going to take what you currently have and help you with it. So the entire life cycle of the provider is here in the symplr and Cactus applications. We have credentialing, privileging, payer enrollment, professional practice reporting, which is your OPPE and ongoing reporting, and peer review, which also includes a workflow tool for other workflows that you have, such as FPPE or risk management or patient safety. It is a great workflow tool that can assist you in taking your current policies, workflows, and making them electronic and automated. So I'll show you that. So the first one I want to start with here is our professional practice reporting. And again, this is the new term, professional practice evaluation, that's being deemed now for peer review as well. So everything is going to be in line with these PPEs, FPPE, OPPE, PPR, PPE, and so on and so forth. So we have called this our professional practice reporting module or product. And the goal of this is to assist you with data capture. We want to make sure that we capture all the data we can so that we can give you outcomes and analytics on this. So we have the ability to provide an interface with your EMR, such as Epic or McKesson or Cerner or Meditech or any of these large EMR systems. And when I say interface, what I mean by that is really a data feed, a data pull. So we're going to be pulling your billing data from your EMR. So we can pull those ICD and CPT codes from your EMR on a weekly basis. And then we'll be able to give you some great reporting on that. And I'm going to talk about that in just a minute. So we have that capability to capture data from the EMR that'll assist you with quality. You don't have to go around gathering papers anymore on everything from everybody. We also have provider privileges available. It's a privileging content library that's included now. And in that privileging content library, Priv Plus it's called, we give you the ability to have your privileges linked to ICD CPT codes. So now we do all that for you. On this end, we do all the research for your privileging. We do all the criteria and content. All of that's included in that provider privileging content library. So with them linked to an ICD CPT code, we then have the capability to give you a privilege to procedure report. So in other words, Dr. Smith might have 5 privileges, and then when we tie those to the ICD CPT codes for those privileges, and then we pull that billing information from your EMR that shows what you have billed for Dr. Smith. And we want to make sure what you're billing for is lining up with what he's privileged to do. So then we can start to give you some of these analytics, and we can do the ICD CPT code comparison. So he has 5 privileges. We pull the codes from your EMR, and we see that he has 4 that he's been performing. So there's one he hasn't performed in a year. That might be very, very important for a focused evaluation or your ongoing evaluations. So we can support you with that. We just have automated evaluation support that way. And we'll let you know that data, and then you can kind of glean your information for your focused evaluations. Because I hear a lot from clients, we know we're supposed to be doing focused evaluations, we just don't know quite how. You know, we can do a simulation or a proctoring or a chart review or whatever the case may be, but deciding how to do that and when is sort of convoluted. So this way, you can look at these reports and say, well, you know what? He hasn't performed that privilege in a year. So that's a good idea for a focused evaluation, maybe at reappointment, to see if he still wants that privilege, or if he can still use that piece of equipment. Maybe we need to do a simulation to make sure he can, or a proctoring to see if he's comfortable, and so on and so forth. So it gives you some really good data for helping you with your other evaluations. Then we have all the comprehensive analytics that we can give you, and actually you can run these with your own click of a button. As I talked about before, you'll have filters and parameters and things. You can save more than one report that you like. We have hundreds of standard reports you can run with the click of a button. Really any field of data that we have can be reported off of, which is nice. So you can start to kind of design and customize your own reports and things that you might want to run. Now, this is a sample. To be really candid, I was going to try to actually run one of these in our system, but I decided for time's sake, and also just for a webinar across the system's sake, this would be safer. If you want to see me run one of these in our application, feel free to set up a webinar demo with one of the sales team. I would be more than happy to show you this live, you know, and pull it up in our application and show you how to do it. You would have the capability to run this yourself. We're going to train you how to run your own OPPE report. And some of our clients have more than one that they like as to how they want the data displayed. So this is a great example of one of our OPPE reports. I have changed the name to protect the innocent, but this is some good real data. This is an OBGYN, and her name is Dr. Griffin. So when I ran her OPPE report, I have chosen some filters that we have in that report, and I just pointed and clicked at the filters that I wanted to include in her report. So here you see I have pulled her case counts by role here on the left-hand side of the screen. So I see that she's had cases as the admitting, attending, consultant. She's a family physician as well, apparently, ordering, secondary surgeon, proceduralist. So she's had several different roles here. And if you notice, they don't add up here at the total unique patient encounters. The reason for that is she was probably the admitting, attending, and consultant on more than one patient, or a combination of these roles on more than one patient. So you'll get her actual case counts per role. Now, where do the roles come from? They come from the credentialing application and how you've assigned those roles to her. So we're gleaning data here from the ICD CPT code pool, as well as the Cactus credentialing application and the privileging application that are tied to those codes. And that's how we glean this data. Then you'll be able to decide, do I want to pull 10 DRGs? Do I want to pull 20? Do I want to pull 5? So you can actually set those parameters and determine how many you want to pull. So I pulled 10 here. So I have her top 10 DRGs, her top 10 diagnosis codes as the attending, her top 10 inpatient discharge statuses here on the bottom left, top 10 procedure codes, and top complication codes. So this is my inpatient ICD data that I've pulled. The next page will show us the outpatient or CPT data that I've been able to glean on her. If we build for it, I can show it here. You'll notice some hyperlink looking numbers there. That just gives you the ability to drill down into the case itself, the patient's information there. This is where the ICD CPT code pull comes in to play from your EMR. So if we're pulling these codes, we can then show you the code on the left, the description of the code, and then how many she's performed there on the right under count. And again, a very useful tool, not just for Joint Commission audits or running your OPPE report, for a management tool for your physician leaders and your quality folks to say, okay, looks like Dr. Griffin is performing 16 of 7309 here toward the bottom. You know, her colleagues are performing an average of 10. So why is she doing more on average than her colleagues? And maybe it's very, very explainable. Maybe that's her specialty. Maybe that's what she does. it could be a coding error on her. So there could be several reasons for it, but it's a great discussion tool to say, do we want to do a focused evaluation to determine why that's happening or what's going on with her? So these are great reports that you could run at any time yourself, just to see what's going on with her. And again, I have some HCPCS and CPT codes included here that I can review. Maybe she's an employed physician, and we're looking at her practice and her CPT information there. The next area that we include is a privilege to procedure report within this OPPE. It's an embedded report. And this helps you understand her privileges and how many she's performed of that privilege, because again, our privilege and content library will tie those codes to this. The red area just shows you privileges that she's currently performing that she's not privileged to do. So that's certainly a red flag. We make that red. Might be a coding error again. It might not be accurate, but we need to look at it because apparently we billed for something that she's not privileged to do. We'll also give you some benchmark data here. The first line shows her individual provider averages there, the readmission rates, length of stay, average charges, mortality rate, CMI, and so on. The second line would compare her to her specialty, which is OBGYN. And then that will give you the averages for her specialty in your facility. And then the third line will give you some information across the system with all the specialties. So her hospital benchmark data, you can compare everybody there and what your averages are there for that. Then we can pull in data from our peer review area or our workflow area where you can trend and track indicators. So I have pulled in the fact that we are looking at some Joint Commission competencies here on her. And also we've had a Sentinel event with her, and that's a peer review probably action or something. So with symplr, we have 3 quality products. We have the PPR, which is your OPPE report, which is what we're looking at now. We also have the peer review application or product where we can trend and track these things in a workflow process. And we can choose, I think there's about 500 or 600 indicators in there already. And you can click on drop downs and just choose those. I'll show you in just a minute. We have a slide for that, but I can pull in that data here if I want to in this OPPE report. The second product that I've been discussing is our peer review application. Again, this is a great workflow tool. It can take your current peer review processes and automate them. So if you're trying to get data from 6 different people and have papers that you're taking to a committee, and you've got physician in hallways talking to other doctors as part of your peer review or on the golf course or whatever, we want to make sure that nothing is left undone or abandoned or unopened here. So we want to make this an electronic workflow, an automated workflow for you. It is very configurable. It was designed to be configurable, and we want to make sure that it mirrors your bylaws and your policies and procedures and the things you're doing. So we would assign a project manager on our side, on the symplr side, to work with you to teach you and train you how to set up your workflow and your task and the things you're doing. We certainly want to attach your images, your forms, your documents, your letters, and so on in that product so that you can have them accessible via the web and via the product. So you would be able to generate forms or letters or documents within that application. And then you want to be able to complete things within the application, review forms online. We're also creating a product now as an enhancement where physicians can have their workflow in there as far as approvals and committees and things like that. So it's a really great tool. You can assign work groups within it and determine who is a work group and who has access to what work group and so on and so forth. So it just takes your whole workflow and makes it automated. And then of course we can trend cases. We can include scorecards if you're using those, if you're still scoring things for FPPE and OPPE. Those details and things can be put in there and reported off of. And then you can also trend and track things. You know, how many medication errors have we had? How many return to surgeries have we had? And so on and so forth. And this is just an example of one of our workflow charts. This is one that Horty Springer uses It's really nice design. It's the Professional Practice Evaluation Process Flowchart, and that just is an example of a peer review process, or a PPEC now they're calling it, for the committee instead of peer review. And here you can just see how it starts with the quality department, it goes to a department chairperson or a leadership council, and then it goes on to my PPEC committee or my MEC. So we'll take your workflow. As you're looking at this, just imagine yours. We're going to take your workflow and teach you how to make that electronic. I also have a sample here of an FPPE workflow. So the nice thing about this tool is you can also set up your FPPE workflow in here as well, and choose whether you're doing a peer review or an FPPE. You might also have an OPPE workflow or a risk management workflow or other workflows that you all use. And you can configure those and have different workflow processes in here. And then you can add a case here. So this is all drop-down, point and click. You see these drop-down menus. We'll show you how to configure those to your departments, your specialties, your referral sources, and so on. And then you can put your entire case description here in a Word format. And there's just, I think, thousands of characters here, so it's pretty well unlimited as to how long that can get. And you can put what the case description is. What are we doing? What are we reviewing here? What's going on? And then the second thing you're going to want to do after you generate a new case is you're going to want to attach indicators to that. So we want to make sure that we can trend and track these indicators. So you'll be able to run reports from those. But everybody can also see these attached to the case, so we know what we're trending and tracking here. And then you'll have cases in progress. So each work group can forward the case to the next work group. So you don't want to lose that seamless process. So that whole process becomes seamless and becomes automated. So the first work group, such as quality, can forward things over to another work group here, such as a physician reviewer or the committee or whomever. And then this page just allows you to do some management of that. You can see everything going on here. You can see which work group has which case, what the reason for referral is. You can link cases together as well if you want to start trending, you know, all of a certain specialty, or you want to start trending all your anesthesia related cases or whatever the case may be. You can link things together here by category. These little icons to the right are just ways you can manage. Some of them mean they haven't opened the case yet. Some of them mean they have and they're adding things to it. The little triangle means it's expedited, and the big stop sign about a third of the way down means it's time to close that case. So we have icons available to help you manage your cases overall. So this page just kind of helps you do that. You can also determine who has access to this area. If I'm your department chairperson and I log in with my user ID and password, you might just want me to see my cases here instead of everybody. So we can certainly configure it that way. And this is just an example of a scorecard. We're able now to take these targets and improvement targets into every peer review indicator. So we can do your patient safety indicators with triggers and show that here as part of your process, your evaluation process here. So if you're still doing those scoring type of things, we can help you with that. We also have, as I said before, lots of standard reports that can be run with a click of a button. You'll see some case history reports here. Some popular ones are the indicator reports by provider, by department, the case history reviews for peer review, case log, and things like that. So a lot of these are really nice. And then up there in the top right is where you would run your own OPPE report and choose your filters and things that you want to pull into that. We also have an application that I think is really nice. Again, these three products are designed to be seamless and all under one umbrella. And also you have the capability to send a event over to peer review, the peer review product with a click of a button. So that's nice. We have over 650 indicators and sub-indicators that you can choose from, and they're all categorized for you. So we have like HRQ for PSOs. We have Sentinel events. We have all kinds of different indicators in there, Joint Commission, competencies, FPPE. So whatever you're wanting to analyze or trend or track, you can certainly click on those and pull those in, and then later pull them into your OPPE. I really like, too, in the event reporting area here, the indicators to choose from, because you can choose from more than one. If you want to trend and track 2 at a time, maybe at a fall and a wet floor. And with each category, we have subcategories within that. And I'll show you an example of that. We have communication assignments. So you can have folks text messaged or emailed when things happen. Maybe I want to be notified when a death happens. I can receive a text message when that occurs. And then it can also be used on any device, an iPad, an iPhone. You know, they can pull up the incident or event report form and fill it out. That's nice in the hospice or nursing homes or home health and other facilities that may not have access to the internet in the hospital. So since it's web-based, they can use it on different devices. And then, as I mentioned before, you can send an event over to peer review. This is an example of the events or the categories of incidents or events that might happen. We'll put them in categories like this for you. And then on the incident report form, they can choose a category and then subcategories from that. So this particular one gives me some of those subcategories under fall. So what type of fall was it here? And they'll be able to choose these things on the incident report form. And then later you can trend and track them. How many assisted deploys have we had this year? And so on and so forth. So this is just an example of some of those indicators that we have in there, which are nice in the system. And again, we have these there for you to choose from. You don't have to go find them. This is the event manager area. All of your incident report forms that have been filled out are located here, and then you can begin to manage these. Maybe it's not a real event, you just want to close it out. Maybe you want to assign it to someone else or notify someone else. Maybe you want to create a workflow to send it to a committee or someone else in the organization and put it through your process and so on and so forth. So this is a great management tool here with all of your events. This is the actual event view that helps you manage as well. This is the event report or incident report that has been filled out. And then your managers or directors would have the capability to change this, to edit it, to assign it, to add notes to it, to save it to your desktop, and so on and so forth. So it has a lot of capabilities here for you to manage the actual incident or event here. And you all will deem who's appropriate to do that in your organization. And then last but not least, this is a great report. I love this. This is just a broad overview of your events, and you can run this with a click of a button. You just choose your filters here. But I can see, you know, what month did most of my events occur in? Well, June. Okay, so in February, maybe I had people on vacation in June, and that's one of the reasons we were understaffed. What day of the week are most of my events happening in? Looks like a Tuesday, maybe Monday and Tuesday. So maybe I need to take a look at that. Why are they happening so often on a Tuesday? What time of day? Well, it looks like around noon. Maybe we have a lot of folks at lunch or whatever the case may be. But this will help me as a nurse manager or floor manager or whatever to start to look at these things and say what's going on. These are reports that you can distribute to each department and let them see. You know, for instance, here I've had 25 events in emergency medicine with this pie chart. We got a problem, obviously, in emergency, so I need to probably attend to that first. And then on the right-hand side here, this is your hot list. You can actually drill down into these events and see what's going on. I've got the most falls here, 19 falls. So these falls I need to probably attend to first before the other events. So that helps you manage everything. And I know I've talked a lot and taken up most of our time with this. Hopefully it's been helpful to you. If any of you would like to have a demonstration of one of these products, it would take probably about an hour to walk through it. And it's a good time for you to see more in depth how we can help you do these things. Just let your sales team, your salesperson for your area know, and we can set up that demo and help you with that and let you see a little bit more of the product and how it would work in there. And I think, Callie, we're going to have a minute here for a couple questions, if anybody has any.
I have not gotten any through at the moment, so I think everyone's kind of working on digesting it. You know, this was a lot of info.
And their lunch.
Yes, and their lunch. And by all means, if y'all want to hear more, you can reach out to Joni and your sales rep, and she'll definitely walk you through everything in a more in-depth level. Since we don't have any questions roll through, Joni, can you hit the next slide for me?
Sure. Maybe.
We do already have next month's scheduled. The topic will be preventing physician burnout. It is with symplr's Jan Law. She is the one that's been doing this presentation at our roadshows, if y'all have had the opportunity to come out to that. If not, you can attend it here, and it will be NAM CEU certified. I am waiting to hear back from them on it. But it is taking place on August 10th at 12 p.m. Central. Let's see, I did have a question roll in. Let's see what it says. Do you send your slides out? Yes, Ms. Olga, we will be sending them out. It will take me a day or two to get them online in the resource library, so be looking for them early next week in your email inbox to ensure that you get this, and announcements about other webinars from us. Please add communications@symplr.com to your address book. All right. I think that's about all we have, Joni, today in terms of the questions. If y'all think of questions after this presentation is concluded, y'all can reach out to Joni. Her email information was at the beginning of the slides. If not, reach out to communications@symplr.com, and I will forward those on to her as well. Joni, is there anything you want to say in closing?
I don't think so. I appreciate everybody's time and attention.
All right. Well, thank y'all, and have a good day, everyone.
Thanks. Bye-bye.